Hey y'all, it's me, Dr. Smeener Gyno Girl. I'm back here again. I know I take a lot of breaks because my life becomes hectic. For those of you who follow me on Instagram or my other socials may know that my mother passed away recently, so this has been a very traumatic loss for me in my life, and so I've been kind of doing a lot of grieving and reevaluating and everything. But I've had so many people reach out to me, and so many of my followers and patients and everything, just, with the great support, are so grateful for the content that I'm able to produce that I'm trying to slowly get back into it. I've been reposting some podcasts that were previously recorded, but hopefully I can kind of get back to a more steady routine after the new year. But I wanted to post today about something that's been coming up in the office. I've been back in the office, and it's really around intrauterine devices and pain control. And I think that there's been a lot about this happening on social media in the past few months, actually, and the CDC came out with this. So we're going to talk a little bit about IUDs and what I like to do for pain. So let's get at it. Hey y'all, it's me, Dr. Smeener Gyno Girl. Again, I am a board-certified gynecologist in downtown Chicago. I am also a menopause specialist and a sexual medicine specialist. I'm part of the board of the International Society for the Study of Women's Sexual Health, as well as a certified menopause clinician through the Menopause Society. And I love educating so others can learn to advocate. I have my own podcast, Gyno Girl Presents Sex, Drugs, and Hormones, and I'm on a bunch of socials as well. And so I try to come on YouTube as much as I can, though life gets hectic. Please like and follow me here. Please follow me on my other channels and listen to my podcast. I think a lot of people are gaining a lot of information over there. But today I want to talk about IUDs, the intrauterine device. And I want to talk about really how we can get better pain control. The CDC put out this recommendation recently in the last few months, mainly due to all of the amazing women on social media who have really spoken out against the lack of pain agents for women getting IUDs. Now, I've been putting in IUDs since I've been practicing OBGYN. That's 18, 19 years now. So even before I sort of specialized and made my practice more about menopause and sexual medicine. But it's very interesting because we were never told or never really given options for women for pain. And if you've ever had an IUD placed or a biopsy of the endometrium or anything that is super invasive that we do in the office, it hurts. And it hurts like hell. Spoken from someone that's had some of these done too as well. But the reality is, back when I was a resident, we were actually told that the cervix doesn't have any nerve endings, which we know is not true. We know there's actually 3 nerves that innervate the cervix, the hypogastric, the vagus, and the pelvic nerve. And actually, when I was a resident, we were taught the nerve was insensitive. And I think that came back from a 1953 Kinsey report when they really noted that in sexual response, the cervix wasn't involved. And we know this is totally untrue. It's founded by the fact that in the last, I would say, 5 to 10 years, as a sexual medicine specialist and as my mentor, Dr. Irwin Goldstein, has actually written about many times, is that women sometimes who have what they think are vaginal orgasms actually have cervical orgasms, and they sometimes lose this sensation whenever we do procedures on the cervix, such as LEEP, these loop electro-excisional procedures that are done to remove abnormal cells of the cervix for precancerous changes. And so it's very interesting that, for the longest time, based on historic probably patriarchy and misogyny in general, that we do not offer women pain control when it comes to these things. And so I've changed my practice a lot when it comes to an IUD insertion and procedures and biopsies in my office. Number one, we should know what is an intrauterine device and why does it work. So an IUD is a device that's placed in the office, and a small procedure takes, 10 to 15 minutes in the office, especially for those of us who've been doing it for a while. I like to call myself a gyno ninja because I can get in and out very quickly and very effectively. So when it comes to an IUD, it's an intrauterine device that's placed in the uterus, if you can see in this diagram, and it's a device that sits there. We have to place it in the uterus, set you up starting as if you're having a pap smear. We then, put a speculum in the vagina, look for the cervix, which is, the opening to the womb. Then the instrument is placed on the cervix. And then we advance the intrauterine device with its applicator in. And pretty much, we're shoving something inside of your uterus, so it does hurt. It causes cramps. Remember, IUDs are very effective forms of contraception. And so actually the number of IUDs placed has gone up tremendously in the United States. It used to be something like 2% of women were getting IUDs. I think it's more like close to 11.5% or something like that. And that's gone up tremendously because of all the new IUDs that we have to offer. And remember, they're very effective. They're just as good as being sterilized. So, you have a less than 1% chance of pregnancy with these devices. And it's kind of like you just get it and you forget it, hopefully, if there's no complications. And it's been great. We've had an 18% reduction in unwanted pregnancies. So it speaks volumes to its effectiveness and, the fact that a lot of women really like it and go for it. And anytime there are concerns about, women's reproductive rights and what's happening, I have a surge of patients coming in to get an IUD because they're concerned that they might have issues in the future. So in the United States, we have a copper IUD. That's a copper-based non-hormonal IUD. So we have the copper IUD, first of all. Copper IUD is a 10-year IUD. It is a non-hormonal IUD. It is placed in the uterine cavity, and it works by really prohibiting the sperm from getting to where it needs to go, affecting motility. And so for a lot of women who actually are, either afraid of using hormones or concerned about the impact of their hormones on how they feel about themselves or their emotional status, a lot of people get symptoms from, the progesterone and some IUDs and or in birth control pills, and they want to stay without hormone. This is their best option for a long-acting, reversible contraception. We call them LARCs. And so good news is it's a 10-year IUD. You just get it in and you don't think about it again. I think some of the bad news would be some of the side effects that we see in the office. I see patients who have heavier flow. So sometimes the patients will go from nothing because they're on birth control pills that are suppressing their hormones and suppressing their cycle to getting a copper IUD, and all of a sudden they're getting heavy flow. So they might have a 7 to 10 day cycle, and it can be sometimes very uncomfortable and painful, crampier than expected. And of course, IUDs do not prevent ovulation, so all of a sudden some people notice like a pain in the middle of the cycle that they didn't have before, one side or the other. So that is something to look out for. And then we have 3 different types of hormonal IUDs in terms of the amount of hormone in them. There is the Mirena and the Liletta, which are now considered, the Mirena is now considered an 8-year IUD. It used to be considered a 5-year IUD. It has 52 milligrams total of levonorgestrel, which is a progesterone. And progesterones can work by inhibiting the growth of the lining of the uterus. So people that use the Mirena IUD oftentimes don't get a period or they have really light flow, and it's also FDA approved for heavy bleeding. And that is why we often use the Mirena IUD in conjunction with menopausal hormonal therapy when people have issues around their progesterone that they're using, the pill or if it's a combination patch or whatever, to control not only the bleeding but to protect the lining of the uterus. So it has an effect for a lot of women in midlife, even beyond contraception. And also it changes the viscosity sort of the cervix, and it inhibits the sperm as well. And so it inhibits fertilization. It's not abortifacient. There's also a 5-year IUD called the Kyleena, which is 19.5 milligrams of levonorgestrel, and a 3-year IUD called the Skylab. It's 13.5 milligrams of progesterone total. Each of these give you, the Skylab gives you 14 micrograms of progesterone a day. The Kyleena gives 17.5, and I think the Mirena gives 20 micrograms of progesterone a day. And so basically you get these progesterone-only IUDs, and the type of progesterone is levonorgestrel. So, when we talk about the different types of progesterone, some of them have an impact on your testosterone, some don't, meaning that some can cause features of higher androgens, which is the acne or facial hair loss, and others can reduce your androgens. And levonorgestrel isn't an androgen, it doesn't have an androgen neutral effect. So some people, after being on this IUD, even though it's locally absorbed, they can have issues around acne, worsening facial hair. So they can have issues with acne, they can have issues with breakthrough bleeding, nausea, some of these other symptoms related to the progesterone. And so on average, I would say that most of my patients on these IUDs love them, and they have great symptom control with their bleeding. When you have the Skyline, the Kylina, which are the 3 and the 5-year IUD, a lot of people end up with less bleeding per cycle. So I think that's really important. Sometimes they'll still have no bleeding in their cycle. So it really does thin out the lining of the uterus. Doesn't prevent ovulation. So people that want to have fertility work done, getting their eggs frozen, whatever, can do it with the IUD in place, which is kind of cool. And so it doesn't also prevent cyst formation. So if you are someone that is prone to having painful, we all make cysts every month when we ovulate, but sometimes they can get bigger or filled with blood or other things. And so if you're someone that's prone to the painful cyst bursting, then maybe the IUD is not the best thing for you. I like the IUD. I often will switch patients off of birth control pills for the IUD, particularly when we have patients that have what are referred to in other videos as hormonally mediated vestibulodynia. Remember, a lot of people on birth control pills have enough testosterone suppression as well as natural estrogen suppression that they end up with the syndrome of hormone deficiency that's acting on their vulva and their vagina. And so they get that pain at the opening, they get labial regression, they get smaller clitorises. I talk about that in a vestibulodynia episode, and the genitourinary syndrome of hormone deficiency. And so this is something that we can use in patients because we don't have this higher risk of getting lower amounts of testosterone in your system. We're getting, maybe higher amounts potentially, but because we're seeing a lot of patients get more acne and everything, potentially, if you're prone to hormonal acne. Some patients that never get any. But those are the pros and cons when it comes to that. But I will often switch someone off of a pill because they have hormonally mediated provoked vestibulodynia, that pain in the vestibule caused by, hormonal deprivation, leading to painful sex, urinary frequency, urgency, all the stuff. And I'll put them with an IUD and we get local estrogen, testosterone to the vestibule, and they do much better. So, these are reasons for IUDs that we're using other than contraception, the bleeding control, again, not an abortifacient, but it is something that prevents fertilizations. And that's kind of how it works. And so the big topic I wanted to talk about was around what we do for pain management. Now, CDC came out with this recommendation saying, hey, listen up. If you're able to control patients' pain, you should use an IUD. I did an Instagram video on this, and it was really highlighting some of the articles that were out about women and who were getting IUDs placed, and they were documenting it on social media, and the pain that they experienced was so profound that the Center for Disease Control put out this statement and said, hey, you know what? This is not okay. We need to be thinking about patient pain control. So what are your pain control options? Number one, we can do a block, a nerve block. We can do a paracervical block where we put needle through into the vagina, into the cervix, and try to numb that area. Doesn't always work for a lot of patients. Some people don't want the needle in the cervical area, so they're cautious about that pain they might have anyway, and they might not want it. So that may negate your ability to do that. Sometimes we'll use Cytotec or misoprostol in the vagina for patients that have never had pregnancies or had their cervix dilated for any reason. Sometimes that will mitigate any difficulty getting through the cervical os. And remember, the Kylina and the Skyla IUD actually were created for what we call nulliparous women who've never had pregnancies because they're smaller IUDs. You can see this comparison in this picture. The Mirena is the standard size, and so it used to be thought that we couldn't use this IUD in women that had never been pregnant. I've placed them in women who have been pregnant, who haven't been pregnant. So it's not a significant issue if we can prepare the patient well enough. So by allowing them I oftentimes will give patients Xanax before they come in. So I'll prescribe them the Xanax and have them take it, when they come in and right before they do it. And so they'll oftentimes have, at least less anxiety coming in, because when you're anxious, you're going to clench your pelvic floor and it's going to be more difficult to see the cervix and the opening. So we can do that. You can take Cytotec in the vagina, 2 tablets, put it in at least 4 hours before you come in. A lot of patients who might have a little bit of stenosis where the cervix is so small you can't get past it, that might help. Getting it done during the time of your period when the cervix might be a little bit open anyway might be helpful to reduce pain. Using topical lidocaine, where we use the instruments using a different type of, there are new instruments coming out to grasp the cervix. We have to grasp the cervix to stabilize it, to insert the IUD. And so there are new instruments coming out that are not as sharp and pointed and look like medieval times. So, and I use sometimes a smaller type of instrument. You can see these comparisons here. And so that might be something of benefit as well to cause and reduce pain there. Some people, and I've done this before, take what is an endometrial pipette that we use for biopsies of the lining of the uterus and place some lidocaine in that and then just shoot it into the uterus, which, there are some people that find that to be helpful. There's a study that came out at ISWISH last year where people were using a vibrator at your belly button. And so during the time of the insertion, they put a vibrator at their belly button to distract them and also to maybe provide a little bit of different sensation here, so that it did show that people had less pain at their IUD insertion. So there are local injections, there are topical lidocaine, there's prepping the cervix, there's giving Xanax, there's taking Motrin, ibuprofen beforehand because the uterus is contracting sometimes after the IUD is placed, and it'll reduce those contractions and cramps, and maybe you could take it throughout the day. That might be beneficial, and I always recommend that if you're able to tolerate non-steroidal anti-inflammatories like Motrin or ibuprofen. And finally, the big thing I've implemented in my office like 2.5 or 3 years ago is this. It's called Pronox. Pronox, remember, is an analgesic. It reduces pain. It does not prevent pain, which is what an anesthetic does when you go under. So remember, an analgesic is something that reduces pain. That's what Pronox is. Anesthetic is something that will prevent pain. So we use that in the office. And sometimes because the individuals will breathe in and out through a system, like you can see this picture, and basically inhale, exhale that nitrous oxide oxygen system. And then eventually they will find that they are laughing or feel high or, feel a little euphoria. And they just breathe in and out, and that also relaxes them a little bit. And basically, it's a game changer in my office. I've had people laughing through their IUD insertions, which has never happened, but has happened for me in the last 3 years. So that is Pronox. And then there's IV sedation. So for some of us who do procedures in our office, we can get IV, we get anesthesia that comes in. So there's these mobile anesthesia teams that come in. So once a month, I do procedures in my office. The mobile anesthesia team comes in. I find that patient is very anxious or is concerned about the pain and really just doesn't want to deal with it at all. We can actually put them to sleep for that. So there are options available, guys. That's the whole point of this video. There are things that you can be done. There's things that can be done to help your pain, to mitigate your pain. We give pain medicine to men all the time for various types of procedures, and we should be doing the same for our female patients, and we should be doing better so that you don't have to be traumatized every time you have a gynecologic procedure. And that is, something we should all work and strive to be better clinicians and do better for our patients. And I use that Pronox system a lot. It's wonderful. I use it for endometrial biopsies, colposcopies, vaginal Botox, lead procedures, all the things. Anyway, that's basically what I want to talk to you about. A little bit of IUD talk today because it's been on my mind for a while. Remember, I'm Dr. Smeederman. I'm Gyno Girl. Thank you for joining me on Gyno Girl TV. Please join me for another episode when I'm able to do one. And I'm here to educate so you can advocate for yourself. So please like and subscribe to my channel and tell me other good content you want to hear. Bye.